I would like to introduce Claire Steiner. In the wake of COVID-19, education, as we all know, has changed dramatically, with many educators pivoting to remote learning technologies to hold classes, workshops, trainings, and other activities. For nurses and health workers at large, this sudden shift has compelled them to rapidly adapt to new ways of communicating health materials normally delivered in person to patients and their loved ones, other health workers and communities. And all of this at a time when many health workers, the backbone of the COVID-19 response, face increasing rates of burnout and mental distress, as Craig so beautifully shared. In this session, Dr. Claire Steiner shares best practices on creating, implementing, and measuring virtual trainings for health workers. Dr. Steiner is a medical doctor and has a master's of public health, a clinician turned public health specialist with over 10 years healthcare experience. Dr. Steiner is currently the health information advisor on the TRACE project at ICAP, where she supports 7 countries in sub-Saharan Africa to stand up surveillance systems to track and respond to recent HIV infections. Dr. Steiner has worked throughout sub-Saharan Africa directly with non-governmental organizations and local ministries of health, supporting programs ranging from disease surveillance to community health worker programs. Thank you for joining us, Claire.
Thank you, Susan. Just one moment while I will share my screen. And while I do so, I also wanted to provide a special thank you to Dr. Spencer for that presentation and that emotional and powerful plea to also recognize the mental health and the burden on health providers at the front line. As a former clinician who's worked in ERs myself, that really resonated, and it's a very important issue. So I think you can all now share my see my slides.
Yes, looks great.
Great, thank you. So I'm going to switch focus a little bit, as Susan mentioned, and talk about some of the work we're supporting in Africa during this time. So we have a program that we're gearing up to scale up nationally in 7 countries in sub-Saharan Africa and introduce to yet more countries when COVID-19 put a pause on 2020. So we had to adapt and not to give in to paralysis and fear, but also to make sure whatever we did was going to be safe and not add additional stress to an already very stressful time, and to continue with our work safely. So today I want to go through with you some solutions and innovations that were born out of this crisis. Since many people in this audience may not be familiar with the TRACE project, I wanted to take a minute to give a brief overview of what we do and some achievements to date, and to highlight the impact of COVID-19 on our program. So then I will talk about why we've turned to virtual training approaches and discuss some of the considerations we make for each training to determine the most suitable approach for the context. We will then share examples from a number of TRACE countries on how they have approached the virtual training, and each has a slightly different flavor. So TRACE stands for Tracking with Recency Assays to Control the Epidemic. Its goal in countries nearing the HIV epidemic control is to establish an HIV-1 recent infection surveillance system in routine HIV service settings to detect, characterize, and monitor and intervene in real time recent infections among newly diagnosed people living with HIV. Essentially, we are rolling out a new rapid test for recent infection in HIV testing services across these countries and capturing the data real time to inform prevention and treatment interventions. The program is a central mechanism funded by PEPFAR through CDC, and we partner with the University of California, San Francisco to implement the program across 6 countries. So there is a resource website here listed at the bottom with articles on recency, validation, study results, FAQs, training materials, dashboard templates, a recency cluster response tools, webinars, etc. So remarkable progress has been made toward the HIV epidemic control in some high burden countries, but many gaps remain. Identifying people with undiagnosed HIV infection, especially those who have been recently infected, is essential to realize the individual benefit of rapid treatment initiation and to prevent HIV transmission to others. A new rapid HIV test that can distinguish a recent HIV-1 infection, or one that's acquired approximately within the last 12 months, from a long-term infection, now offers new opportunities to improve the health of people living with HIV and to advance public health efforts towards epidemic control. So at ICAP at Columbia University is working in collaboration with ministries of health and local organizations to roll out the rapid HIV recency test in selected high burden countries as part of a comprehensive approach to respond to the epidemic. Frontline nurses are the backbone of HIV recency surveillance and critical at every stage. Through building their capacity to detect recent infections, they are best equipped to respond to individuals who test recent, to enhance or activate additional services to curb further transmission. At a higher level, having public health responders with frontline nursing backgrounds and intimate knowledge of the context to help analyze and interpret trends in the data, identify locations and at-risk populations, and then lead the public health response with targeted HIV prevention and active case finding, we are much better able to understand the epidemic and interrupt further transmission. So here I have summarized some key achievements. I won't speak to every number, but in summary, we have trained around 2,500 certified testers, and these are predominantly nurse counselors and lab personnel across 8 countries, and have activated recency surveillance, including 300 plus master trainers. Nearly 1,500 HIV testing services have conducted around 31,000 RT-RI tests. Countries are seeing a 10 to 15% recent infection rate among newly diagnosed HIV positive cases. And in a few countries, we are working with surveillance officers. So these are nurses or clinical officers who have received specialized training in HIV response, have started responding to time-space clusters of recent HIV-1 infections to gain insight into what might be causing the clustering of these infections and making recommendations for improving HIV prevention. On April 10th, PEPFAR released guidance pertaining to COVID-19 pandemic, recommending a temporary pause in recency testing. The aim was to minimize the time clients spent at the clinic to reduce potential exposure for both clients and healthcare workers. During this time, 5 trace countries who are supporting recency testing paused their implementation. Here you can see a screenshot from the Lesotho recency dashboard that shows the impact of this pause. The yellow line you see here are new HIV positive cases, and you can see it continues though at a slightly lower rate. So testing and identification of new HIV positive cases continued. However, the recency testing, you can see the line stopped short in April, indicates where the program had to pause. The map on the right shows how different countries altered implementation in response to PEPFAR guidance. Rwanda and Eswatini, in blue, continued training and implementing testing. In yellow, you have Nigeria, Ethiopia, Tanzania, and Lesotho, who all paused recency testing while COVID restrictions were in place. And then in red, you can see DRC, who were able to launch their recency testing program in the midst of the COVID-19. Even in countries who decided to continue with recency surveillance with appropriate precautions, the impact of social distancing was felt. Here you see the numbers from Rwanda, where the volume of recency testing declined by about half since social distancing guidelines were put in place, but testing has continued. So as in any project, introducing a new technology, and in this case, HIV-1 recency assay, in-person training is the backbone of establishing the recency surveillance. In the last 2 years, we have followed this 3-step training process shown here, where we relied on expert trainers from the CDC International Lab Branch and ICAP to conduct training of master trainers as step 1. The same people customized training materials, and the master trainers certified during the step 1 training of trainers cascaded down trainings to on-site staff. Step 2 typically was centered around facility-based staff, where central staff based in the capital needed to travel to different regions around the country. We also carefully maintained a 1:6 trainer to trainee ratio throughout all of our trainings to ensure quality quality results. After scale-up of testing and collection of data for about 3 to 6 months, in step 3, we organised in-person data use workshops that allowed participants to dig into the data through numerous hands-on exercises, as well as to define a public health response strategy for recency based on trends observed during the workshop. A typical training involves 4 core components. Didactic sessions are a lecture type presentation or moderated discussion where theory is delivered through a 30 to 45-minute session. And these will typically provide trainees opportunities for questions, feedback, and group discussions. Practical sessions are central to ensuring HIV testing providers are confident and competent in rapid test for recency process and interpretation. Testing procedures are taught through supervised practical sessions with opportunity for hands-on practice using pre-prepared testing panels, as well as opportunity to practice documenting results using electronic data capture forms, etc. Then, to provide opportunity for participants to cement their knowledge, trainees were provided with take-home materials shared for private revision and practice. These would be in the form of written or practical assessments observed or reviewed by facilitators. And finally, the knowledge assessment, or in other words, the certification of master trainers or trainees on surveillance procedures. We would deploy pre and post tests, observational checklists, and practice panel responses to assess knowledge attained and to certify our trainees. So traditionally, training relied on subject matter experts traveling to the training sites from both headquarters, but also from country central offices to regional locations to give live didactic presentations and practical sessions to training rooms. With the advent of COVID-19 and eventual resumption of local travel and in-person meetings, with the resumption of local travel and in-person meetings well before interstate or international travel resumed, we needed to think about how we could remotely support trainings in regional locations to restart, start new, or activate testing sites, even now while flights are grounded. So we needed to find a solution that would enable facilitators anywhere to be able to access the classroom, lead trainings, interact with participants, and ensure knowledge is transferred accurately despite restrictions on movement. We also wanted off-site facilitators to be able to observe practical lab sessions, track and review progress in real time, lead recap sessions, and monitor assessment components and intervene to support any struggling students. When we started to think about novel training approaches, we wanted to ensure we were able to not only deliver, but deliver in a way that ensures we wouldn't compromise on quality. That the training would be as, if not more, engaging for participants, ensuring that they do not lose the ability to ask questions and interact with facilitators, but also allow off-site subject matter experts to adequately assess knowledge and provide feedback to trainees. We took a few examples from the Mailman School of Public Health online learning department for approaches for virtual training, sampling from some recommended best practices. A flipped classroom. Now, for those who are not familiar, a flipped classroom takes advantage of the before, during, and after class time for learning opportunities. Before class, students will prepare to participate and begin engaging with course content, reading, watching lectures, doing exercises. During the class, students practice applying their knowledge and engaging with instructors. And then after the class, students check their understanding and extend their learning through homework or additional exercises. We made use of pre-recordings to help guarantee content accuracy and to reach participants in remote areas with poor internet connection. We also made use of short cycles of teaching, practice, and recall to cement knowledge. And we tried to create as many new opportunities for interaction as possible to try to maintain engagement. We quickly realized, though, that virtual training does not suit every type of training we conduct through Trace, and had to answer core questions regarding participants, facilitators, available resources, and local guidelines before we could move ahead with one approach or another. We knew that short of a virtual reality or a VR approach, that we will have to have some in-person instructional time. We knew we wanted to minimize the time of this in-person instruction to limit potential COVID-19 exposure. So we thought we would move to some of the content to virtual platforms. And the questions you see here, we would ask at every new training. How rapidly do we need to deploy? Is there local capacity who could facilitate these trainings? Do participants and venues have good audio, visual, IT, projectors and other sort of equipment to support the training? Do participants have good computer literacy? I think that's an assumption that we have here in the US, but it's not necessarily guaranteed with our frontline providers in some of the countries we support. Do all participants have access to stable internet? And how strict are the local restrictions on movement and small gatherings? We also found that certain components, such as lab practical, had no option but to be in person. And so in the end, we sort of fell in the middle and adopt a mixed or hybrid virtual in-person approach. So here we have listed out some of the COVID-19 precautions taken by countries when implementing trainings. We attempt to ensure a cohort of trainers and trainees stay together for the duration of a 2 or 4 day training to limit exposure. We ensure daily messaging goes out to participants to not come to training and to stay home if they're feeling sick. To do daily symptom and temperature checks on arrival, and ensure venues have large, well-ventilated rooms or explore outdoor venues if possible. We also recommend having a dedicated COVID prevention champion who is responsible for ensuring guidelines on social distancing, mask wearing, hand washing, etc., are all followed by the participants. We ensure to have PPE available at every training site and to sanitize rooms and shared surfaces at every opportunity. So that gives you an idea of the background and some of the thought processes we went through before deciding on different training approaches. So now I'll go into the examples. So in Nigeria, we had a series of training. We had training of trainers and we had step down trainings. I'm just going to show you the example of our training of trainers for now. But our colleagues ran a 2-day training agenda with 1 day of theory and 1 day of practical sessions. They adopted the flipped classroom approach very well, where participants were asked to complete exercises before and between sessions. So before the training started, participants were registered in a Google Classroom where they would find a pre-test quiz as well as some pre-recorded presentations that would be delivered on the first day. They would answer a series of questions related to the content and practice this through online quizzes, and they could review their results and revise as many times as desired. Then on day 1, in the training session proper, this was conducted completely remotely. Participants joined from home or private offices. These didactic lessons, so lectures and discussion type sessions, were presented by trainers located around the globe. We had trainers in South Africa, Malawi, Zambia, and the US, all streaming into the classrooms in Nigeria, not only in the capital, but in some of their state capital offices as well, using existing IT infrastructure and the Zoom platform. So like in-person training, we were able to engage with participants in dialogue and also make use of other features such as polling questions to test knowledge and ensure participants were paying attention. So also through Zoom, virtual breakout rooms were used to allow multiple parallel sessions in a single conference call for streamlined movement between sessions, much like walking between rooms in a physical training venue. So this was particularly useful when we had parallel laboratory and data practical sessions being implemented at the same time. So after day 1, another set of pre-recordings and quizzes for lab content, including testing procedures, performance, specimen collection and transport, etc., were released again through the Google Classroom for our trainees to complete at home ahead of the second day. So these interactive modules had pre-recorded lectures cut into short clips and embedded into forms with multi-choice questions. So the participants could go through, submit their responses, compare their responses to an answer key and repeat as many times as needed until they achieved 100%. So this set a foundation for the lab practical session on the second day, so that in-person time was minimized. So of all of these 4 sort of components of the training, only day 2 for 2 hours was in person. So on day 2, lab practical sessions, as I mentioned, held in person. Participants would get hands-on practice with rapid test for recency procedures under supervision. The challenge here was how would we connect our offsite trainers, as I mentioned, South Africa, Malawi, Zambia, USA, with the participants in the room. So we made use of the Zoom video conference platform. In addition to a photo capture of test strips that would be submitted through the Google Classroom. So these would go to a central repository where our offsite facilitators were able to review and intervene as needed. In future, we're planning to use a setup with a light and smartphone attached to a tripod to stream lab procedures to offsite trainees, as our colleagues at UCSF have been doing in Thailand. So moving now to the second type of training that we deploy, the step down training. Quite a different approach was adopted by Eswatini. So they had trainers located at central offices, leading a 2-day training for trainees who remained on site at their health facilities. And they were able to train up to 5 facilities simultaneously and conduct this 2-day training. In this approach, the technical officers from the ICAP Eswatini office would travel to facilities to help trainees connect to the online training platform. On day 1, the ICAP staff would set up a laptop, and we see here in blue representing our ICAP staff, would set up the laptop with internet, a data bundle. They would log into Zoom or MS Teams, and up to 5 trainees per site could connect. For this day, the training was conducted completely virtually. So the trainer over here on the left was sitting in Babane head office and would disseminate the lectures or lead the discussion with the participants at site. This session would cover theory and discussion through a series of lectures. So to ensure HIV testing services were not interrupted and to support our nurse providers at these sites, an HIV testing trained nurse counsellor from within the surveillance team would then cover the routine testing services so our trainees could focus on the training being provided. Then on day 2, a laboratory technologist with training in HIV surveillance would conduct in-person practical sessions. During this day, nurse trainees would get practical experience in the rapid test for recent infection, testing procedures, recap lab theory from the previous day, recording results and data collection, as well as requirements for certification, as I mentioned, post-test, direct observation assessment, and competency testing. The added benefit of this approach is these sites could be immediately activated. So this means they would pass a checklist that would authorize them to start HIV surveillance activities at the site. And typically this step is planned as a separate activity with dedicated travel out to sites to do this, but they could wrap this all up into 2 days while they were finishing up the training. And finally, an example of our third type of training. As I mentioned earlier, after 3 to 6 months of data collection, we organize in-person data use workshops that allow participants to dig into the data and have hands-on experience and define their public health response strategy for HIV recency. So typically this has been a week-long workshop held in country with the Ministry of Health or district health officials traveling to the capital and facilitators flying in from elsewhere in sub-Saharan Africa or the US. To adapt this to a remote learning approach, we cut the training into modules of 8 2-hour sessions that we would hold over 3 weeks to enable offsite facilitators across time zones to participate. So we adopted a flipped classroom approach here again. And during the session, we would use the Zoom platform for lecture style presentations and moderated discussions, making use of polls, again, to test, review and discuss core content for training modules, provided cues to facilitators where there was need to slow down, recap or focus on particular concepts or course correct. We then made use of the time between sessions for participants to complete exercises based on content and skills taught during the session, either as private study or in groups. All exercises and quizzes were submitted into the Google Classroom, where facilitators could access, review results, and hone in on problem areas for recap and revision during the following daily session. So here we have a taste of what a data use workshop looks like in practice, with panelists and attendees dialing in from Lesotho Ministry of Health, the National Reference Laboratory in Maseru, Laribe District Health Office, Johannesburg, New York, Atlanta. And it's very nice to see all of the faces there in the one screen. I think we miss that in-person time greatly when we're doing things all virtually and working from home. And so with a combination of these methods in Nigeria, Eswatini, DRC, and Lesotho, we've successfully completed 4 TOTs, 3 step downs, and 1 data use workshop since COVID-19 restrictions. And we had a very high completion and a certification rate among trainees, and our best metric of quality, and a testament to the fact that we could still deploy our trainings without compromising on quality. So just as a final, or second to final slide, just some quick lessons learned along the way. You know, we learned that one size does not fit all. We have shown just 3 examples here, but we are quickly learning that each training brings a different combination of challenges and computer literacy, equipment, connectivity challenges, or availability of on-site expertise, and we must navigate these to tailor training to local context. We also learned that the preparation for setting up such trainings requires substantially more time than our traditional approach, as everything must be thought of and addressed before you launch, as there's little opportunity for addressing issues on the fly. I mentioned internet here because where it was not available, we did need to adapt to a digital yet offline approach. And we found the best way to mitigate some of the issues with computer literacy was to have an on-site virtual training champion available to troubleshoot and orient participants. We also have here some feedback from our participants, and I think we can all agree that short presentations with quizzes are more engaging than long lectures and homework. I think we can also agree that live presentations and discussion are preferred over pre-recorded sessions. And that also being in a class with colleagues while maintaining social distancing is much more enjoyable than participating from home. So finally, another plug for the e-learning hub. So if anyone is interested in learning more about Trace and find more information about some of our different approaches, but also additional resources around HIV surveillance generally, please go to tracerecency.org. The link again here for you. So thank you to ICAP colleagues in offices all around Sub-Saharan Africa. Thanks to UCSF and PEPFAR CDC for your support, and to the rest of the Trace team here at ICAP at Columbia University.
Great. Thank you so much, Claire. We have a few questions. We'll take time for 2 of them. And if you have more questions, please share them in the chat box, and Claire will respond to you personally. Do you have data on the efficacy of the flipped classroom compared to what you did prior to COVID-19? And which is more efficacious? Are they equivalent? Were there things that you found worked better with the flipped classroom? Could you say a bit about that?
Yeah, absolutely. Great question. Thank you. So I think our best metric for quality is the test, the post-test results and our pass rates among participants. In Eswatini example, they had no difference between their sort of centralized training approach versus this on site-by-site semi-virtual approach in terms of the pass rates. Both were 100% actually. So I think that's a testament to the quality there. In Nigeria, also very high pass rates. Only a few did not pass in the first round, but with quick remediation and intervention to improve just for those subset of testers, they were able to bring them up to speed as well. So very little difference across the 2 countries that we've completed so far.
There was one question about the quality of the visuals of the test strips using those virtually. Was there any challenge with that you had to overcome?
Yes, and that is something we are still trying to overcome. I think there's a lot of differences in terms of the platforms and the quality of the camera that you use to try and capture the photo, around guidelines for the distance, around the lighting, around all of the parameters that need to be quite tightly controlled so that you can ensure that you're capturing a very good image. I think sometimes participants are comfortable with platforms like WhatsApp, which reduces the quality of the image through transmission. And so we're continuing to deal with that. One of our approaches is to adopt, as UCSF did, this ring light and tripod setup where you can control the distance and the lighting, and have that sort of preset so you can ensure the quality of your images.
And do you see ways in which what you have learned from Trace can be used in other outbreaks and epidemics to better use data at the ground level to actively inform program improvement and going where the needs are greatest?
Yeah, and I actually think it works both ways. So I think the Trace program is benefiting from the expertise in country of the staff that we are bringing on who have faced multiple outbreaks and epidemics of different natures. And we heard about Ebola, and, Rwanda is an example. We have our colleagues, I think, listening in. They have had Ebola on their door, repeatedly over decades. And so they had systems in place already to be able to respond rapidly. But in addition to that, our teams, both from the strategic information side and the data management side, but then also the surveillance officers, our nurse trained frontline responders, were able to take what they had learnt and the systems in place from HIV recency surveillance and quickly pivot. And they were best positioned to support the Rwanda Biomedical Center or the Eswatini Ministry of Health with their COVID response, and were able to deploy dashboards, build that culture of reading and responding to the data, and to be able to be on the front line and to help provide the services where they're needed.
Great. Thank you so much for taking the time to share this and to show what can be done when you have to quickly regroup and do things a different way, and to have very strong outcomes with new and innovative approaches to capacity building amidst crisis. Thank you so much. There's some more questions in the chat box that I'll ask that you comment on to the individual participants. We will move on in the interest of keeping to time, but thank you again.